need is a rapid and cost-efficient test that is able to support that diagnosis. Again, CT scan is a type of X-ray cost, so it is basically having radiation exposure, and in some cases, contrast is used. So you have contrast-induced nephropathy. So again, we want something that's non-invasive, okay, that can support the diagnosis of this condition. And then again, when you're looking at accuracy, for each 2% loss of a D-dimer test sensitivity, 1 patient per 1,000 may die because of a missed PE. So again, we want accurate test results. We want the right type of a D-dimer test and not just any other test. So PE is life-threatening and is always suspected in any patient who is presenting with shortness of breath or chest pain. So let's go back to the first slide where I talked about the symptoms. Shortness of breath can be infectious, but it can also be PE, okay? And it can also be cardiac, such as an ACS. So again, that's not a specific symptom. Chest pain, the same thing. So the physician or the clinician in casualty, their first thing is to suspect that maybe there's also a PE here, because it's life-threatening. If you don't suspect it and you don't treat it, then the patient will most likely die. Now, it needs to be diagnosed. Again, I talked about the gold standard. PE is usually diagnosed by the CTPA, which is the CT pulmonary angiogram. Okay, so it's basically a type of CT scan that is specific to the pulmonary circulation. But again, as we know, this is costly and it has side effects. And by the time you're in casualty and you ask for CTPA, by the time the patient gets from casualty to radiology and gets the CT done, you might actually lose the patient, okay? So again, we're not saying we don't do the CTPA, but we need something that helps us as we are waiting the CTPA and maybe any other test that is to be done. Less than 20% of suspected patients will have a PE, hence the challenge of differential diagnosis. Now, you'll suspect 100 patients, but only 20 of them. Sorry, could you please mute?
Thank you, Esther.
Hello, kindly mute your microphone. Okay, so I hope I'm unmuted because I was trying to wait for you to mute everyone. Thank you very much. So you have 100 patients who you're suspecting to have PE, but only 20 of them will actually have a PE. So the other 80, you're suspecting them to have PE, but you might actually be dealing with other things, okay? And then the last point, which I'll now explain in more detail in subsequent slides, is before you test, you need to do what is called a clinical pre-test probability assessment before you do the D-dimer. So there's something that actually helps us before we do the D-dimer, know which patient the D-dimer will safely give us the correct result, okay? And I'll explain that in more detail in subsequent slides. So how does D-dimer come in? We're talking about venous thromboembolism. And how does it come in to support the exclusion? Now, you'll note the term we're using here is exclusion. So not all tests, and I'm sure all of us are, as good laboratorians know, not all tests are for confirming a diagnosis. Some are actually for excluding. And D-dimer is, in this case, for venous thromboembolism, it's actually an exclusion test, okay? So the first thing is, maybe I want to just give an overview of this D-dimer and what it is. Again, just to remind us as a refresher what it is responsible for in the normal circulation. So when you have coagulation and you have fibrinolysis occurring, usually D-dimer is released, okay? So when you have coagulation or formation of a clot, the clot is actually called a fibrin clot. And then when you have the fibrinolytic system coming in to break down that clot, you have a lot of things that are released, which are called fibrin degradation products, FDPs. And then the presence of those FDPs is characterized by the D-dimer epitopes, okay? So as a clot is breaking down, you have D-dimer expressed more and more. All right. So basically, the more you have a breakdown of a clot or fibrinolysis for that matter, then that is expressed by the presence of an increased D-dimer. So normally in healthy individuals, it's present, but when you have venous thromboembolism or any other coagulation process or other fibrinolytic process for that matter, there's actually an 8-fold increase. So it's quite sensitive in picking venous thromboembolism, all right? Now, the normal D-dimer plasma levels will basically mean that you're very unlikely to be having a VTE, all right? Now, there's a caveat though. D-dimer is not specific for venous thromboembolism. I mentioned that it's sensitive. As you can see, 8-fold increase, it is sensitive, but it's not specific because it can increase in many other conditions, okay? And there are quite a number of conditions that can also increase venous thromboembolism, or rather can increase D-dimer. And actually one of them is COVID, I can mention, because some of you have seen D-dimer being requested in very sick COVID patients. Now, there are two steps in using D-dimer in venous thromboembolism. Now, this slide is quite busy, but I'll take us through it very systematically. So remember I said the first thing you must do is a pre-test probability, what is abbreviated here as PTP. So a pre-test probability is done clinically, all right? So the clinician will run a score to rule in the likelihood of this patient actually having a VTE. Now over here, these scores usually incorporate risk factors, clinical features, and clinical judgment. And there are quite a number of scores. I've listed 3 over here. You don't need to know all this because this is mainly going to be handled on the clinical side, but it's good to know that this should ideally be done, okay? So once you score the patient using any of the scores, you will get high probability or highly likely, low or intermediate probabilities. Now, if you're highly likely to have venous thromboembolism, you actually don't necessarily need your D-dimer because it means the score was quite accurate in saying this patient is most likely having a venous thromboembolism. But in practice, many people will still do the D-dimer because they want to have something also as an additional evidence. Now, if it's highly likely, you continue the examination, you'll follow up with imaging. And at this point, you must do the ultrasound, the CTPA, and the VQ scan, as well as other investigations for differential diagnosis before you treat for venous thromboembolism, all right? Now, where D-dimer is really useful is in this group that we're calling low or intermediate, because the score is showing maybe this patient doesn't really have VTE or they could. This is where we have a problem. And this is really where we must do the D-dimer. So again, you might do the D-dimer and it says negative and you say, oh, okay, so the score was actually right. So you don't need to examine the patient and you confidently rule out pulmonary embolism and DVT in at least 30% of suspected patients. That is why we are calling it an exclusion test. Because you did your pre-test probability, you got a negative D-dimer, you're confidently ruling out in at least 30% of the patients. So it's an exclusion test, okay? In this case, again, you don't need to do any further testing. Of course, you investigate for other causes as to what is happening to this patient. You don't need to start anticoagulant treatment. Again, you save a lot of costs because you're not doing other tests and you're also not starting unnecessary treatment. So D-dimer comes in especially in your low or intermediate group of patients, intermediate risk group of patients, if you use these scores, all right? So again, you can see here we are integrating a clinical score and a test, a laboratory test, in this case a D-dimer, which is then helping us have a quick and easy way to discriminate suspected VTE patients. And then you're able to categorize them into those groups and decide who really needs the D-dimer test. And if your D-dimer is negative, then you can confidently rule out the PE in the patient. So I'll stop there just to see that we're still together. Maybe Kamau, you can unmute just to confirm that we are still moving at the right speed, at the right pace.
Absolutely, we're doing well. I will just wish to check whether there is any question as it stands. Looks like we don't have, at least for now. So probably you'll just proceed and then I'll keep checking. Thank you.
Okay, asante sana Kamau. Great. So if you forget anything today for D-dimer, remember this one slide. It summarizes pretty much everything. I think there's just still one person who might need to mute. I can hear a bit of background noise. Kamau, if you can help me with that, I'll really appreciate. Thank you. So we've talked of the 2 steps. And again, this slide is just to emphasize the previous one, but it has some additional information I'll talk about. So it's a bit better pictorially presented. You can see the first step, clinical pretest probability, performed by the clinician, who then categorizes the patient into low or medium, which is unlikely to have VTE, or high. And if it's low to medium, this is where you must do your D-dimer test. And it's called a D-dimer exclusion test. So if it's negative, then you can safely exclude or rule out pulmonary embolism or DVT. And the figure presented there is less than 500 micrograms per liter as the cutoff. If it's positive, then you continue examination for PE and DVT and of course proceed to management. Again, there are some age-adjusted cutoffs which also increase your sensitivity when you're looking at D-dimer. So instead of just using the one conventional cutoff, which is 500 micrograms per liter, there's a recommendation that you actually look at the age times 10 as the age-adjusted cutoff for patients, because again, things change as people grow older. So using one single cutoff for a 50-year-old and using the same cutoff for a 95-year-old or a 90-year-old is not ideal. So you have an age adjustment that you can do to ensure that you're actually using the correct figures for making a decision. And again, this age-adjusted cutoff, just as I've mentioned, it improves the clinical utility of D-dimer for safe exclusion by offering a 1.3-fold higher exclusion rate. All right. So safe exclusion, 30 to 50% of patients in the low and medium pre-test probability groups. That's the take-home message for D-dimer. That's the key highlight of the discussion that we're having so far on VTE. Now, there are some caveats, and want to present them because, as you all know, no test is perfect. So you must always have this at the back of your mind when making decisions for the patient. The first one, for you to have safe exclusion of VTE in patients with low and intermediate PTP, you must have a high sensitivity D-dimer assay, not just any D-dimer assay, but one that is highly sensitive. If you have a less sensitive D-dimer, then the D-dimer assay should be limited to patients with low or unlikely, because they should not be limited, that should not be limited to low or unlikely. D-dimer should not be used in patients with a high pretest probability because despite a normal D-dimer value, approximately 1 in 10 patients still have pulmonary embolism. So remember the group we talked about, the high pretest probability. Yes, the D-dimer could be elevated, but sometimes it's also normal. And in that case, if you have a high pretest probability but a normal D-dimer, you should still treat as though the patient has venous thromboembolism, because treating is safer in that group than the risk of missing it, okay? And then again, in the case of suspected pulmonary embolism, this algorithm is only valid when the patient has hemodynamic stability. When the patient has shock or hypertension, you must then do immediate CT pulmonary angiogram or echocardiography when the CTPA is not available. So again, in this case, this is obviously more for the clinicians, but just something to know. It's only valid when the patient is stable hemodynamically. Sensitivity and net predictive value are very key for the safe exclusion of VTE. Again, I've talked about sensitivity. And when you have a highly sensitive assay, which should be as close to 100% as possible, then you're able to minimize the number of false negatives, all right? And that's a very important point. Of course, this is something that you must take into account as you select the correct assay that you're going to use. I just want to talk briefly about the cutoffs in terms of what the CLSI recommends. The CLSI actually recommends cutoff of less than or equal to 7.5% coefficient of variation. So for example, in the first side, the one in yellow, this is a very wide margin of a cutoff showing the lower limit and the higher limit. And a high variation can lead to either overdiagnosis or underdiagnosis. So what is recommended is here there's 5%, maximum of maybe 7.5%. Here it reduces the risk of false negatives. So the range should also not be too wide. So again, not all D-dimer tests are created equally. And that is why we want to really promote the VIDAS D-dimer exclusion because it is highly sensitive. You can see the sensitivity is actually at 100%. It also has a high negative predictive value and a coefficient of variation of less than 6%, which is within the recommendations shown in the previous slide. Okay, and there's a lot of studies we can share in detail, but basically it is the best test that you can use for D-dimer exclusion to ensure that the patients with venous thromboembolism are managed appropriately. So this should be the last slide on D-dimer. With the VIDAS D-dimer exclusion, you are safely able to exclude in patients about 30 to 50% of those with low, intermediate, or unlikely pretest probability. You also have an age-adjusted cutoff to ensure that even the older patients, you're using the right figures for exclusion. And again, it's CNFDA cleared for this kind of testing. You'll have better triage. It'll prevent unnecessary radiation exposure. And then it's quite reliable. And it's actually been cited by the European Society for Cardiology on that aspect. All right. So I'll pause there just to check how we are doing, whether we are still okay. Maybe if there's a burning question on D-dimer at this point, I can address it, or we can address it jointly with Kamau. Any question, any issues? Are we still together? Okay, so I'll take that as silence means we can move on. Kamau, maybe you can help me check on the chat, because I think maybe there could be one. Or there's a question on how to get the notes. Don't worry, we'll send an email after this with all this information. Of course, there's some information that we'll have to change a little bit, but we'll send you a very good summary of all this. So I want to move to the second condition, acute coronary syndrome, or commonly abbreviated as ACS. And the biomarker here we're going to discuss is troponin. But I want us to start with the condition a little bit so that we build into the biomarker. I just don't want to go straight to the biomarker so that it's a little bit easier for everyone to understand. So what is acute coronary syndrome? It's applied to patients where we suspect an acute myocardial ischemia or acute myocardial infarction. All right. Now, commonly, we will say heart attack. But for the purposes of this discussion today, I want us to understand that it's actually a continuum of conditions that can present this way, just for our own understanding. All right. So there are three types of ACS that are classified based on how they present clinically and also how the ECG appears. Now, ECG is the electrocardiogram. It's a very basic test that is done at casualty when you suspect a patient has acute coronary syndrome. They are classified into three, and I'll go into the classification on the next slide in more detail. Myocardial infarction, as I mentioned, usually we refer to this as heart attack, but it's basically a combination of either ischemia, where there's reduced blood flow to a part of the heart, or necrosis, where the reduced blood flow has actually led to cell death in that part of the heart. Okay, so you have the vessels of the heart. If you have a blockage there, it causes a reduced blood flow to a section of the heart, or a complete blockage of blood flow, and then it leads to cell death in that part of the heart. So this is basically, it shows how clots normally develop. And for those of you who know this very well, the common risk factors is obviously hypertension, diabetes, our diet, a lot of nyamachoma and such things. They lead to the formation of these clots, and this leads to occlusion of blood flow to the heart. Okay. Now, they are classified using very complicated terms, which you're seeing here, and some of you might wonder why we need all this. The reason for this is because when you're looking at troponin, you actually must look at it from this perspective. So the mildest condition is called unstable angina. You have reduced blood flow, very minimal occlusion, and no necrosis. Okay, nothing happens to the section of the heart. You just have reduced blood flow. The ECG normally appears like that. The next one is what is called non-ST elevated myocardial infarction. The ST is a segment on the ECG, and basically it's not elevated. The one that has ST elevation looks like this, where it's elevated a little bit compared to this one. And basically here you have severe occlusion, and here you have complete occlusion. So the table here is a bit more easier to understand. Ischemia without necrosis is unstable angina. Ischemia with necrosis is either non-ST elevated or ST elevated. And ST elevated, you have complete obstruction of coronary circulation. Usually this is fatal because it's very hard. Unless you treat very fast, it's quite hard to get out of that one. But you see, the challenge is they all present with chest pain and associated features. So how do you know the differences? And that's why it's important. Because a patient like this who has no necrosis, you may not really be in a hurry to manage as compared to the one who has complete obstruction. So again, ECG is able to give you a baseline, and ECG will be done quite quickly in casualty, especially to pick the ST elevation, which is very important in classification because it tells you who requires which kind of treatment. But the cardiac troponin, it comes in to support especially the 2/3 who don't have the ST elevated, who require either conservative or early invasive approach. So troponin is coming in to reduce the guesswork because ECG is not able to give you everything, only 30%. Now, what if the ECG is normal? Sometimes it's normal, sometimes it's not easy to interpret. The troponin comes here to, let me say, save the day. All right. So myocardial infarction or heart attack requires early diagnosis. As we all know, and we all keep seeing, very many people succumb to heart attack even before they get to hospital. So the faster we can get this done, if we do things late, then we're increasing morbidity and mortality, obviously, all right? If we rule out late, then we're keeping the patient in hospital, increasing the cost, increasing the anxiety, all right? So the doctor, the clinician, is stuck between two problems. They don't want to miss a case, but they want to confidently rule it out. So early diagnosis is critical, and that's where beyond an ECG, a troponin or a biomarker such as troponin is very useful in supporting the diagnosis. So we've talked about the clinical features. They're not specific. If somebody has chest pain, it can again be so many things. If you remember the first slide, it could be an infectious cause. It could be venous thromboembolism, which we've just discussed. It could also be a heart attack, all right? And again, ECG may miss out some cases, all right? So it's not easy to just use ECG and clinical features. So how does troponin come in? So let's start with why troponin, because there are many cardiac markers, and that's a whole other lecture. But this graph summarizes why troponin is the gold standard. So you can see the various biomarkers. You have the one in blue is myoglobin. You have dark green and light green troponin. And then you have CKMB, which is in yellow. automatically you can see the differences visually. Myoglobin might come up early, but it goes down quite early. So this is not a useful biomarker, because what if you test the patient, somewhere here? You're not going to see a change, a significant change. You really have to capture it quite early. CKMB has a similar problem. In fact, it comes in later than troponin in terms of rising, and then drops quite fast. So again, it's not a useful biomarker for especially monitoring. Troponin appears to be the best, okay? If you have STEMI, which usually should pick on ECG because it's quite clear, then again, it'll be very clear that it was rising up to a very high limit, and then it starts to come down, especially after interventions. The lighter green just shows if it's a small infarction. It will come in and stay for a while. Again, this is very useful because here, remember, the ECG can be a bit of a challenge. So this one can help you be able to understand what's happening to the patient. So unlike CKMB and myoglobin, the release of troponin IOT is specific to cardiac injury. So it's a mark of cardiac injury, and it's actually released before CKMB. I know some labs still do CKMB, and I hope after this slide, they will understand why CKMB should really not be done. We know there could be a cost issue, but as you can see, what is the benefit of a cheap test that is not really helping you long-term? Okay. So troponin, or cardiac troponin CTN, it's a marker of cardiac damage or cardiac injury, and it is specific for that. Now, it is not specific for myocardial infarction. It doesn't mean troponin equals heart attack, but troponin elevation means there's something happening to the heart, there's damage happening to the heart, okay? And the challenge then is there are many other conditions that can elevate your troponin, and the list is quite long over here. We won't go into that list. So you must use it as a supportive tool, okay? And you combine it, of course, with all the other clinical features, the ECG, and then you use it to make a decision, all right? Again, it's supportive. Again, all troponin assays are not equal, yeah? So again, back to sensitivity. We talked about high sensitive D dimer. Now we're also talking of high sensitive troponin. And our troponin is troponin I, the one on VIDAS. And in this study that was published in 2011, they concluded that in patients with suspected ACS, implementation of a sensitive troponin assay increased the diagnosis of myocardial infarction and identified patients at high risk of recurrent myocardial infarction and death. Myocardial infarction can actually be recurrent, okay? So you can have an MI today, it's treated, and again, it comes back. So again, lowering the diagnostic threshold of plasma troponin was associated with major reductions in morbidity and mortality. Now, the graph on the right explains it even in better visual detail. Now, this is how troponin behaves, okay? This whole graph that has three colors, green, yellow, and red. Normal levels, they vary below, they stay within normal, just going up and down because other things are happening in the body. When you have a possible MI, it starts to rise. And then when you have an acute MI, it rises sharply. Now, this line over here shows the cutoff for a contemporary troponin assay. This lower cutoff here shows, this lower line here shows the cutoff for a high sensitive cardiac troponin. Now, what you can automatically see is with a high sensitive one, even when you have a possible myocardial infarction, it starts to rise, okay? Or it starts to be detectable. Whereas in the contemporary assay, it really needs to rise much higher for you to be able to detect. So again, sensitivity is key because you'll miss these patients, yeah? These ones you will get even with any other assay. But here we are talking about sensitivity because of this group, okay? And again, we still need to intervene here because if there's something happening to the arteries supplying your heart, we must intervene because your heart must be supplied with blood because it's the one pumping blood to the rest of the system. So we cannot allow it to have even a drop of blood supply of any kind, okay? So we must intervene. So those with a possible MI are detected and managed earlier with a high sensitive cardiac troponin test. And this, of course, has a clinical benefit to the patient. Okay. And sensitivity matters. This is all from the ESC guidelines, European Society for Cardiology. I won't go into all the details. This is, I think, the most important bullet point. Due to higher sensitivity and diagnostic accuracy for the detection of acute MI presentation, time interval to the second cardiac troponin can be shortened with the use of a high sensitive assay, okay? Because you might need to repeat the troponin. And this may reduce substantially the delay to diagnosis, translating to shorter stay in the casualty and lower costs. It is recommended to use 0 to 3 hour algorithm as an alternative to 0 to 1. That is more clinical. So again, high sensitivity assays, reducing the time interval to the second test, and also helping you pick the possible MI patient, okay? Now, serial testing is useful. So we don't just do troponin once, get a high value and say, okay, we have acute MI here, and you walk away. You want to get another value to see the delta. Now, this delta, first of all, shows you how fast is it rising, okay? And it actually shows you you're definitely having an acute MI, but the delta also helps with differential diagnosis. So how the graph changes varies across various heart conditions. If we start with myocardial infarction here at the bottom, what we're talking about, this is typically how the troponin will behave in that patient in several days. If it's myocarditis, it will not rise so sharply and it will start to drop. If it's chronic heart failure, it will probably remain the same. So this also helps us in looking at other possible causes. Remember, we said it's not specific, it's sensitive, but it's not specific because other conditions can also raise the troponin. But it's quite significant for myocardial infarction, as you can see. So this is what the guidelines say in terms of how to use a troponin. These are the ESC, European Society for Cardiology guidelines, which a lot of people use even in our setting. This is a generic algorithm because they want you to include other things depending on where you work. So you have acute chest pain. If you do your high sensitive cardiac troponin and it's less than the upper limit of normal, if the pain has been there for more than 6 hours, then you can exclude other differential diagnosis, discharge, and do other treatments. If it's been there for less than 6 hours, you retest within 3 hours. If again, there's no change, then you proceed as if this other channel. But if there's a significant change to upper limit of normal, you consider invasive management. Of course, if it is higher, if it's more than the upper limit of normal, then you'll most likely retest after 3 hours. And if there's a change, you do invasive management. Again, if there's no change, despite being at a high level, then you also can work up a differential diagnosis. So again, this is generic and it's been adapted to different settings. If we look at it, how it's presented in the VIDAS, it's actually presented as a 2-hour algorithm, okay? So you're able to actually do things in 1 hour less. Let me put it that way. So we are trying to do things a little bit better than the guidelines. So if you have, and here the clear figures put in, so if you're less than 2 nanograms per liter, you can rule out that this is acute myocardial infarction. If it's between 2 and less than 100 nanograms per liter, sorry, this is the observation zone. And after 2 hours, you retest, okay? If it is less than 6 nanograms per liter after the 2-hour test, then again, you can rule out with a sensitivity of 97.7%. If they change between 2 hours, if the change between time 0 and 2 hours is more than 10 nanograms per liter, more than or equal to 10 nanograms per liter, you can rule in with a specificity of 95%. So we have a 2-hour algorithm, which is quite in line with the 3-hour algorithm of ESC. But again, with 2 hours, you're able to give the patient benefit earlier, because remember, we're talking about myocardial infarction, which is quite a serious condition that usually leads to death. So I'll stop there for acute coronary syndromes. And again, check that we are still together. I hope we're still together. Maybe Kamau, you can alert me if we...
Yes, absolutely. We're following and all good so far. We only have one request for notes, and I'm sure we will be able to summarize everything later and share. Thank you.
Yes, we'll definitely share the notes. Don't worry about that. The email might come latest by tomorrow because, as I mentioned earlier, I'm in the field at the moment. So between Kamau and myself, we'll coordinate to ensure you get it in good time. So we are now in the last condition, heart failure. Okay. We've talked about venous thromboembolism, which is about clotting in the lower limb. If that clot breaks, it goes to the lung, the pulmonary artery. It causes what is called pulmonary embolism. The key biomarker there is D-dimer for exclusion, especially for those who are at low or intermediate when you do the test. We've also talked about cardiac troponin, which is for acute coronary syndrome, which is a wide array of syndromes where there is reduced blood flow to the heart and even damage to the heart. Again, when the ECG is not very clear, troponin helps to show the way in those patients. Okay, and now we're in heart failure. So heart failure is usually classified into chronic and acute. We're mainly going to talk about acute today because that's the one that presents as an emergency. Chronic heart failure is usually something that patients actually live with. They're on management. It's progressive. In the early stages, not easy to detect, but patients who are picked in good time, they're usually on treatment. Okay. Acute heart failure is a sudden worsening of the function of the heart with a very high mortality risk. And again, just like in many of these conditions, the clinical signs don't tell us much in 50% of the cases. So if clinically you can't pick things properly, then you definitely need a biomarker to help you. So the diagnostic challenges of heart failure, similar to the other two, again, the symptoms are usually not specific. If you look at this list, and you'll have the notes so you can look at them for yourself, it doesn't really scream heart failure. It can show up in many other conditions that we face. So again, clinical picture is sometimes not very useful. So how do the natriuretic peptides, as they're called, come in, or specifically NT-proBNP? So this is how we manage heart failure in summary. So you have a patient here, you listen to this, you take the symptoms, you examine, you'll find that it's not specific. Sometimes it's subjective because heart failure, you also look at the function. And one of the things we normally ask the patient is, how is your effort level? Are you able to climb stairs faster than you used to climb before? Are you able to stand up and walk a distance of 2-3 meters without catching a breath? That's very subjective. Some of us are better at walking fast, some are not. It's very, very subjective. So not very specific on the clinical picture. If you do the ECG for heart failure, it's not like for myocardial infarction. For myocardial infarction, it's very, very useful. But for heart failure, not very useful. Not specific, very low sensitivity. So your ECG is not even useful for heart failure. X-ray, again, probably the worst. Sorry to say that, but not going to show you anything. You will sometimes see an enlarged heart, as is shown here. But then again, that is not very clear. This last two is where we are really able to pick heart failure. The gold standard is echocardiography, because you take an ultrasound of the heart and you're able to see all the clear features that this is heart failure. You can see it's gold standard. It's an ultrasound, so it's non-invasive. It's not exposing you to any radiation. But again, those who work in hospital setting will know it's not always available. Who is doing the echocardiograph? Most often, it's a cardiologist. Of course, it can also be a technician. But again, it's not available 24/7. You can't just say, go for echo, and the patient gets the echo immediately. And it can be expensive in many of our settings. So it is a gold standard. This is where we need to be for heart failure. This is where we confirm the diagnosis of heart failure. But before we get there, we can use biomarkers, okay? Especially when we are waiting for the echo, okay? Or if the patient, we are still struggling to get the echo, biomarkers come in. because they are sensitive, they are specific. And this is a test you can get 24 hours, ideally. Yeah, of course, depends on the lab, but ideally you can get it 24 hours. So in heart failure, you want to be here. Yes, you will do your clinical presentation, which is very important because the only way you'll ask for this test is based on something here, but you very quickly want to have these two done for the patient. Okay. So there are two natriuretic peptides I want to talk about. Okay. And they're called natriuretic peptides. So the full name here, which is very long, N-terminal pro-brain natriuretic peptides. Very long, I apologize for that. I'll add it in the abbreviations before I send out these slides. And then this is brain natriuretic peptide, okay? I won't go into the history of why they are called brain natriuretic peptide. That's a very long story. But these are the two that we talk about when it comes to heart failure, all right? But the recommended one is NT-proBNP and not BNP, okay? The precursor. So BNP, these are the differences, all right? And one of the key issues that we look at for NT-proBNP versus BNP is the half-life. NT-proBNP has a longer half-life, and that's one of the reasons we use it, okay? And it's quite stable in vitro outside of a human body, more than 72 hours. BNP is not quite stable, okay? And the precision between run and correlation of variation is less than 10%. Okay, that's quite similar, but the accuracy is higher than BNP, all right? So we're talking about the half-life, we're talking about the stability and the accuracy. Those are the main factors that make us use NT-proBNP and not BNP. So again, we look at guidelines because guidelines ideally are supposed to guide us. So European Society of Cardiology, very important organization. 2012, they said if you suspect heart failure, do an ECG and chest X-ray, then do a BNP/NT-proBNP, then you do an echo to confirm heart failure. Of course, you look for the cause and treat. But in 2016, they upgraded it to say you must, in the first step, do the biomarker together with the other tests. Then you combine with echocardiography to confirm the diagnosis of heart failure, acute heart failure. And this is now how we are probably, I don't think the guidelines have changed much, especially for this part. For treatment, yes, of course, we have newer drugs and things like that. So it is a first step, okay? We are no longer discussing whether we are going to do this biomarker or not. It's a question of immediately the patient comes, all right? So the natriuretic peptides, or NT-proBNP, they are used in diagnosis. So you want to diagnose suspected acute and chronic heart failure as well. Prognosis, if you now measure the values, they correlate with the severity of heart failure. And then guiding therapy to follow up to allow therapy adjustment and cost reduction. So this is a critical tool. You'll definitely do your echo because your echocardiography shows you the features of heart failure, which are usually better visualized. But you need the NT-proBNP to guide you in diagnosis, prognosis, and guiding therapy. All right. This one study I wanted to show, it's quite old, but I like it because it shows that when you combine the clinical exam with NT-proBNP, then the efficiency of picking up heart failure goes up to over 92, 93%, okay? So if you're using clinical presentation, it's quite low. As you add NT-proBNP, it goes higher, but when you combine, it's much better, okay? So it's an efficient way to ensure that we don't miss the diagnosis of heart failure. And this is how it's used to guide therapy. So if you confirm heart failure, as we've done previously with the previous guidelines, and you identify the cause, as you're treating the patient, you do NT-proBNP. If it's going down, you have a good prognosis in this patient. If it's staying the same, then maybe you're just stable. But if it's going up, then it shows that the condition is worsening. And there was some health economic data that was coming out of, I think, the US, showed that they were saving $1,000 per patient, which is quite significant even in our setting. So this is probably my last slide, I think. So NT-proBNP and how it really supports the management of heart failure. First of all, it's a reliable test and it's quite stable. Time to result of about 20 minutes. And these are the details in terms of calibration, the sample to use, and so on, the correlation that was used. Minimum time before failure to over 1,400 days. And the kit is in 60 tests as per our current recommendation for VIDAS. It's reliable. So clinically, you're able to triage in the casualty quite efficiently. You want to also reduce the time for heart failure management because you have a tool that's guiding prognosis, diagnosis, and therapy. It's compliant with the ESC guidelines, and I think most guidelines. And then we have the common cutoff values. And then for patients who are on this drug, which is a drug for heart failure, Entresto, it's mandatory for you to do an NT-proBNP. You can't avoid it. At the institutional level, you're able to reduce the stay in the casualty, so you can convince the people who run the A&E that if they were to do NT-proBNP, they'll not be wasting time looking at just the clinical picture of the patient. They're able to quickly rule in and rule out. More accurate and rapid patient management, reducing the cost of therapy, reducing readmissions, and of course, increasing the success of therapy. And I think with that, that should be my last slide. Thank you very much for your attention. I hope it was fairly clear. But of course, at this point, we'll welcome any questions or comments from anybody. So I think Kamau, you will lead the session.
Thank you very much. Thank you very much, Dr. Kiplangat Sigei, even for making time to share with us on these very important topics that were highlighted by some of the participants in our last engagement. We went through molecular diagnostics, and today they wanted you to delve more into cardiac biomarkers. Now, from questions, we do not seem to have any. We only have a request for recording, and yes, we have it on YouTube, and you can be able to access it. The recording is there, and you will allow Dr. Sigei some time to be able to share with us some abbreviated notes from today's engagement, and hopefully in the next 3 weeks, we will also invite him to share on something different. So I want you to I could give you a chance to unmute and ask a question if you have any at this point. If you have a question, you can unmute and ask. Thank you very much for the participants joining us from Malawi. Special recognition to Mr. Anania Moyo, my former lecturer there. That's quite something, and the team from Uganda. So anybody with a question, feel free to unmute and ask your question. We've allowed you to unmute, so if you have a question, you could unmute. If you're not comfortable asking, as usual, you could push the questions to me. I will share it with Dr. Sigei, and Dr. Sigei will be able to get back to you. Thank you once again, Dr. Sigei. Thank you all participants for making time to join this particular session. I would encourage and request you, if you'd like us to cover any topic that you feel we've left out in the last 8 engagements, we are happy to schedule that and reach out to you. If you want our dedicated session at your institution, we are also more than happy to do that. And at this time, we started 3 minutes past the hour. Then I will request that we close this session now that we do not have any questions.
Kamau, I think I saw a hand up.
There is.
It went down. It went up and down quite fast.
So, we have Madam Masingetich saying she's grateful for the insights. Not sure there is a hand up. Would you like me to unmute you? Yeah, you could raise your hand and I could easily do that for you. Well, in the past, Dr. Sigei, they've wished to send their questions discreetly. So we will allow them to do just that, and then you'll be able to respond.
Sawa, hiyo ni sawa pia.
Asante sana for your time and joining us from Zimbabwe. I mean, takes a lot of challenge to connect and all that, and we're really happy that you could make time. So thank you very much.
Asanteni sana. Thank you, Kamau. Thank you.